vegan. I'm going to present joint work today with Daniela from the Vienna University of Economics and Business and Mujaheed Shaikh from Hertie School of Governance in Berlin. And what we're interested in is the relationship between health misperception and healthcare utilization of older Europeans. And when I'm talking about health misperception, I'm basically adding up or taking use of a topic or a concept that's heavily used in economics already, namely that of confidence. So health misperception, health overestimating or underestimating can also be interpreted as over or underconfidence. And confidence was shown to affect behavior in many different life domains. Confident people have completely different investment and saving behavior. Confident people make different education or labor market choices. Confident people are more likely to get hurt, they're more likely to fall-induced injuries. Overconfident people, when it comes to their health, are more likely to smoke, to be obese, to sleep less. And interestingly, confidence even affects how we vote. And confident people are also more likely to become leaders, even if their confidence isn't actually related to competence. So for us, the next natural step is simply to look at how confidence is related to health perception. No, that was wrong. How confidence is related to health behavior. Why is that relevant? Well, in a context of population aging, many policymakers are increasingly concerned about health spendings, which are mostly increasing in the industrial world. But not only that, even the media has picked up now that it's not always the right people that use healthcare extensively. For example, there's a lot of literature out there that says that especially men with lower socioeconomic status, they don't go to the doctor even though they should. So we were wondering if there is a relationship between health misperception and the way people utilize healthcare. It's a priori not clear how the relationship might look like, because for someone who underestimates his or her health, we could imagine that that person goes to the doctor all the time. In the long term, that person might actually be healthier, because if there's something wrong with her, the doctor might find it. On the other hand, it was shown that people that overestimate their health, they're more likely to exercise, which in principle is good for your health. But then they also have more injuries, so we don't really know by theory or a priori what findings we're going to have, so we want to solve this empirically. And the way we're going to do this is with shared data, which many of you, I think, are familiar with. We've heard presentations about it before. So it's the population 50+. We're using waves 2, 4, 5, and 6, and have over 60,000 observations from 15 different countries. The way we proxy healthcare utilization is by the number of yearly doctor visits. We are only talking about GPs here, so no specialists. Also emergency hospital visits. And then a second outcome variable we're interested in is out-of-pocket payments. What's that mean? Out-of-pocket payments that go in hand with these doctor visits. You can see that the mean is 74 euros, but the median is 0, which is pretty typical for European countries because there is health coverage, public health coverage, so not many people have out-of-pocket expenditure when they go to the doctor. Both variables, that of doctor visits and out-of-pocket payments, are heavily right-skewed, which is very typical for this sort of data, and we account for that in our models. So what's more interesting is how do we operationalize health perception? Well, in SHARE, people are first asked, do you have any difficulty getting up from a chair? And after they ask this question, people actually have to get up from a chair. So we know exactly whether this person gets it right, as in they achieve concordance, whether this person overestimates her health, meaning they say, well, I have no problem getting up from a chair, but then when they're tested, they can't actually do it. And the other way around, when a person says, yeah, I'm having problems, but then they can actually get up, which we consider as underestimating. We're not only doing this with the chair stand test, we're also doing this with other biomarkers in the sample, but for now, I'll mainly talk about these results. Just to give you a quick descriptive overview of what health misperception or health perception looks like in Europe. These are the predicted shares of individuals that get it right per country. These are those that overestimate, and we can see that Poland, Ireland, and Southern Europeans overestimate their health. And we can also see that especially Western and Central and Eastern Europeans underestimate their health. We also see that health misperception increases drastically with age. That's all in every country, that's always the top line. You can see that it declines with age. I know the font is super small, apologies for that. And we can see that that's mainly because overestimating increases. That's what's to be expected. That's not actually necessarily a bad thing. That shows some resilience of older people, but it also shows that their health perception changes. Okay, so what we're doing is we are basically estimating the effect of health misperception on healthcare utilization. There is some issue of reverse causation, because if I go to the doctor regularly, I know more about my health. So the way we try to solve that is we regress health perception at the current wave on healthcare use at the next wave. So we try to somehow account for that by doing so. We use a negative binomial model for the count data and a log gamma model for the out-of-pocket expenditure to account for the right skew of the data. The reason we do that, here is an example for the negative binomial model for count data, is that it has a better fit than, let's say, a zero-inflated Poisson or a simple Poisson. You can see that by how well the light blue bars overlap with the dark blue bars. We also have to split our sample into those that are impaired and those who are unimpaired according to the Wittgenstein test. And because, of course, health affects how often you go to the doctor, we account for a range of health variables in our model, but also for other typical demographic and socioeconomic variables such as gender, educational attainment, and most important, risk aversion, since that might also affect your healthcare utilization. And here are already our first results. So a person that underestimates her health goes an additional 1.6 times to the doctor as a person that achieves concordance, as a person that gets it right. Not only that, that person, average person, also spends much more when going to the doctor, namely almost an additional 19%. The opposite is true for people that overestimate their health. So people that overestimate their health, they go to the doctor less often, namely fewer 1.4 visits per year, which is quite a lot, because remember the mean was 7 visits per year. And they also spend much less on doctor visits. So we do a range of robustness tests there. As I've already mentioned, we not only use the Wittgenstein test, but we also look at walking ability, because we can make a subjective and objective health measure there. We also look at cognition measures, where people are first asked about the memory and then their memory is tested. Then also we use different model specifications. We conduct a range of heterogeneity analysis and also different estimation methods, as I've shown you before already. So what we were interested now is, can health misperception or difference in health misperception between genders also explain differences in healthcare utilization? Because I've said before, there is a lot of literature out there that is interested in the fact that men don't go to the doctor. I really like this quote from a qualitative study that men have to be broken and bleed before they go to the doctor. I'm not saying I like it, I mean, I think it's interesting. So we do find that there are differences in the sense that health misperception of men always has a bigger effect on their healthcare utilization than health misperception of women. However, when we look at the confidence intervals, that difference is not actually statistically significant, so there's not so much to be learned from that. Okay, we are still working a bit on our policy implications. I mean, this could be useful to discuss how to motivate people to take up screenings, to take up preventive care. And there is also one big limitation to our study, which is mainly data-driven. we found, so we need panel data for that, right? We need a person's perception now to talk about their healthcare utilization in the future. But we saw that sicker people are more likely to drop out of the sample, which is quite common. So we have to think still about what that means in terms of our results. This is not yet written up, so I'm very much looking forward to your questions later. Thank you.